week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
Karlie Knobloch. She is the PGY2 Emergency Medicine Pharmacy Resident at Michigan Medicine, and she will be presenting the journal article Effect of IV versus IO Calcium versus Saline on the Return of Spontaneous Circulation in Adults with Out-of-Hospital Cardiac Arrest.
Thank you. Thanks everyone for joining in. So we have no disclosures or potential conflicts of interest. And our objectives today is that first we are going to discuss calcium and its current and historic use in advanced cardiac life support. We're going to describe previous literature discussing calcium for out-of-hospital cardiac arrests, and then we're going to evaluate the use of calcium chloride in an out-of-hospital cardiac arrest trial in Denmark. So just for some background, to first start talking about why calcium and why people are looking into this, the mechanism of action is that it does have inotropic and vasopressor effects, which would be beneficial in cardiac arrest, as well as it stabilizes the cardiac membrane. As we know for most ACLS trials, that high-quality CPR and compressions, as well as defibrillation, is the hallmark and cornerstones. And there's a lot of research going into the ancillary medications that we use in ACLS in cardiac arrest to see if there is any benefit in attaining ROSC, or as well as potential benefits in neurological function going forward. So that's why calcium kind of comes into play. Historically, it was used hit or miss for ACLS and cardiac arrest, but the data previously did really not show any positives or benefits. So the current use for calcium in ACLS is really for hyperkalemia, hypocalcemia, and possibly in calcium channel blocker overdoses is what we mostly see it for, because there are risks associated with calcium, just like any other medication that we'll give in ACLS. The first one is cardiac hypercontraction or stone heart. And this is because in ischemia, which patients usually have some sort of ischemia going on during cardiac arrest, there's a decrease in ATP. So sodium will accumulate, and this accumulation of sodium intracellularly will stop the gradient between calcium and sodium. So the calcium is more in the serum, and then you're potentially adding all this calcium on top of it. So you're overloading the body with calcium in that moment. And this can cause the stone heart or this overload of calcium in cardiac hypercontraction. Also, with this overloading of calcium, you can see potentially oxidative stress, release of propionodic factors, and activation of calcium-dependent lipases, proteases, and nucleases as well. So those are some potential risks associated with too much calcium in these patient populations. So to go into some previous literature before getting into this trial, in 1985, or this is kind of the oldest randomized control trials that we have for calcium, there was 90 patients with refractory EMD, which is electrical mechanical dissociation, which is basically your shockable rhythms. And they were looking at calcium versus saline. So they had 48 patients in the calcium group and 42 patients in the saline group. And results of this trial, where they were looking at successful resuscitation, basically showed that the calcium was slightly better than the saline, but really not what they were looking for. So 8 patients were successfully resuscitated in the calcium group, with 2 in the saline group. And of those 8 successfully resuscitated, they all did have a QRS width of greater than 0.12 once they were finally resuscitated. And then the conclusion of this study was that there was a 10% rate of survival to hospital discharge with the use of calcium in cardiac arrest, which isn't the best. And then the second trial was by the same author, and this one was the same calcium versus saline, but in asystole. So it took place during the same amount of time, during the same year. And they also looked at successful resuscitation. And in it, they saw 3 in the calcium group were resuscitated and 1 in the saline group. So this wasn't statistically significant or really clinically significant as well. And then in the calcium group, of those 3 that were resuscitated, they were not discharged alive as well. So they didn't really make it past that like first 24, 48 hour mark. And then in conclusion, from this study, they claim that calcium chloride is not of value for resuscitating patients with refractory asystole in pre-hospital settings. So these were our first 2 before this trial out-of-hospital cardiac arrest looking at calcium versus saline in this patient population. But what they did know, even though it wasn't statistically significant, they claimed that there was point estimates that pointed favorably towards calcium. And that was kind of the gap in literature for where this study came about when they were looking at those previous randomized controlled trials and saw potentially a favorable benefit. So they wanted to kind of recreate the trials and look at calcium versus saline for out-of-hospital cardiac arrest as well. So to get into this study, the purpose of it was to determine if the administration of calcium during out-of-hospital cardiac arrest would result in improved return of spontaneous circulation, or ROSC. They define this as 20 minutes or more of no additional CPR. So sustained 20 minutes without CPR is what they concluded as ROSC, and that was their primary outpoint. For the design, it was an investigator-initiated, placebo-controlled, parallel group, double-blind, superiority, randomized clinical control trial. And they were looking at sustained return of spontaneous circulation for that greater than 20 minutes as their primary outcome. Secondary outcomes, they also were looking at survival at 30 days and then survival at 30 days with favorable neurological outcomes. They noted for the modified Rankin scores of 0 to 3 is what they considered favorable neurologic outcomes for this study. They also took a look at some tertiary outcomes, including quality of life at 30 to 90 days, as well as 180 days to a year. And they also looked at some adverse effects between the 2 groups as well. Inclusion and exclusion criteria for this study. The patients had to be greater than 18 years old, had to have an out-of-hospital cardiac arrest, and received at least 1 dose of epinephrine during the cardiac arrest for being able to be included. So the epinephrine had to have been given before the calcium. This is really important because they included all shockable and non-shockable rhythms, as well as witnessed cardiac arrest, unwitnessed cardiac arrest, and if a bystander CPR was given. So they didn't try to focus on one specific patient population. They really added diversity initially to the study by including all out-of-hospital cardiac arrest to really get ideally like a big patient population and be able to look at different subgroup analyses to see if calcium had a benefit on any specific group or all the groups or none of the groups. Exclusion criteria were traumatic arrests, known or suspected pregnancy, received epinephrine outside of the trial, if they were previously enrolled in the trial, and then if calcium was given for any clinical indication like hyperkalemia or hypocalcemia. They were not included in this study. So the intervention for this study is that they were randomized 1-to-1 to either calcium or saline, and how this was done was during the cardiac arrest, they were given a first dose of epinephrine, and then they were either put into the calcium group or the saline group. If they were in the calcium group, they got 5 millimoles of calcium chloride, which is the equivalent of 735 milligrams of calcium chloride. For reference, we usually give about 1,000 milligrams or 1 gram in a cardiac arrest. And then the normal saline group was just matching that to 10 mLs of 0.9 of normal saline for a placebo. Then after that first dose, they would get a second dose of epinephrine, and then they would get a repeat dose of calcium. And usually it was basically back to back. So they would push epinephrine, and then immediately after they would push calcium chloride if they were to be included in the study, or the placebo, and same with the subsequent doses. Even if more doses of epinephrine were given, they weren't followed by additional doses of calcium. And then other medications for cardiac arrest like lidocaine, amiodarone, et cetera, were allowed to be given in the study. They didn't report it or record it, so I won't be able to tell you which medications were given per which patients or which patient population, but they didn't exclude any of those additional medications during the cardiac arrest itself. For statistics, the original sample size that they calculated was to be 430 participants overall. They assumed that a rate of ROSC would be 25% in the placebo group and 37.5% in the calcium chloride group. So that's what they based their study off of initially, were these rates. As the study went on, which I will talk about more in the results section, from January 2020 to November 18th, 2020, there was only 23 patients in the whole study, basically, that met sustained ROSC, which was lower than anticipated. So they had to increase their sample size as well as decrease their anticipated results. So the new results that they anticipated were 18% in the placebo group and 27% in the calcium chloride group. And then the statistics that they actually use for their primary and secondary outcomes, they were looking at risk ratios and risk differences. And then I talked about subgroup analyses, which they did look at, but they did not power the trial, and the trial was not powered to meet these subgroup analyses, but I'll still discuss them later. But they looked at the initial rhythm, the timing of the drug administration, IV versus IO, so intravenous versus intraosseous, witnessed by ambulance staff, or if bystander CPR was given. So for their inclusion and exclusion screening, originally there were 1,221 out-of-hospital cardiac arrests during the time period of the study. They excluded 824 of them, most of them because they did not receive a first dose of epinephrine during the cardiac arrest, and then as well as there was 40 traumatic arrests. So then with that additional patient population after the exclusion, there was 197 that was randomized to the calcium chloride group, and then 200 that was randomized to the normal saline placebo group. And then after that, they excluded a couple more patients because 4 in the calcium chloride group had traumatic arrests, as well as 2 had traumatic arrests in the normal saline group. So our final patient populations that were included was 193 in our calcium chloride and 198 in the normal saline. So pretty similar between both groups. To get into the baseline characteristics for both, the study only lasted from January 2020 to April 15th, 2021, with a 90-day follow-up until July 15th, 2021. I'll get this more into the results, but the trial was stopped early, this is not how short that the authors wanted the study to go for. So it was cut early at about a year and a half almost. So the age was about the same between both. Both groups were majority male patients. Medical history, there was a bunch of them, but the ones that I found that were like the highest between them was they mostly had hypertension. And I was specifically interested in looking at CKD at baseline or kidney disease at baseline, which both groups had about 20-ish, 18 to 20% kidney disease at baseline. They also looked at the cardiac arrest characteristics. So most of these were at-home cardiac arrests. And what was interesting was that 50% of them in both groups were bystander witness. And then bystander CPR was started in 82% of the calcium group and 89% of the normal saline group, which was pretty high and pretty interesting to see. And then the initial rhythm, most rhythms were either asystole or PEA, so our non-shockable rhythms. And then finally, for our baseline characteristics, most patients had IO access, and that's how they got their medications. And what also was pretty interesting and a little out of the ordinary was the time to administration. So epinephrine and the trial drug, because they are given back to back, were both about 17 minutes for each, which, thinking of our normal cardiac arrest, is a little long to get the first dose of epi in for patients. So definitely had a long time to drug administration that was noted in the study. And then number of trial doses, most patients got the full 2 doses for the study. So about 73% in both groups and 27% in both groups only got 1 dose. So most patients did receive 2 doses of calcium after 2 doses of epinephrine. So for our primary outcome, on April 15th, 2021, the trial was stopped because they noted harm in the calcium group compared to the normal saline group. So looking at the primary outcome here of sustained ROSC greater than 20 minutes without CPR, in our calcium group, there was only 37 patients that were able to sustain ROSC and 53 in the saline group. So the calcium group was doing markedly worse than the saline group in achieving ROSC during this study. It was not statistically significant, but I think this is pretty clinically significant enough that it had to stop the trial. They also looked at these subgroup analyses, like I mentioned earlier, and these patients were anyone who sustained ROSC for even a little bit, so not just based off of the primary outcome listed above. But basically, most patients had shockable rhythms to begin with, and then the time to drug administration, like I said, was about 17-ish minutes. And then for witness cardiac arrest, like I mentioned earlier, most of them were bystander witness, so someone did witness it, and EMS was close by to start CPR. And then for bystander CPR, so not EMS or clinical CPR, it was started in most of the patients in the calcium group and the normal saline group. Secondary outcomes, so they were looking at the survival of 30 days and favorable neurologic outcomes. So the calcium group had less patients survive at 30 days compared to our normal saline group, as well as they had less favorable neurological outcomes as well compared to the saline group. So with our primary outcome and our secondary outcomes, calcium is doing markedly worse compared to just placebo normal saline for this study and this patient population. They did note that there was no deaths or decrease in neurological function between 30 and 90 days for both groups. So that was something to note, that these patients that did survive didn't get worse after 90 days between both groups, but there was still no benefit seen in the calcium group. And you can see that here, looking at the modified Rankin scores in the original 30 days, there was 3 with a modified Rankin score of 5, and no one got worse in the groups, really. Some improved a little bit, but really most of them stayed the same or around the same for favorable neurologic outcomes. Looking at adverse effects, notably hypercalcemia is probably a big one that you would think of when we're pushing calcium in cardiac arrest. The calcium group had no severe hypercalcemias, but they did have a lot of moderate and mild hypercalcemias in the right when patients attained ROSC. And then at 24 hours for patients who did survive, there still was a good amount of mild and moderate hypercalcemia, as well as compared to the normal saline group. They had mostly none. So 98% of them did not have any hypercalcemia, and that stayed the same at 24 hours as well. Looking at acute kidney failure requiring dialysis, there was about 19% of the surviving calcium group needed dialysis, and then that stayed the same in the 24 hours because the calcium group, only 5 patients passed away between the first 24 hours, and 7 of the same 7 required dialysis, whereas in our normal saline group, 2 needed dialysis in the beginning, and then after 24 hours, 3 did. And the normal saline group, 12 patients died between that first 24 hours. The study didn't tell us if any of these patients that required dialysis did have CKD at baseline or not. So it's hard to figure out if it's because of where they were at baseline before they had this cardiac arrest, or if it was due to the calcium itself. But I do think it's pretty interesting who needed dialysis after, or if it's even due to the calcium at all. But it's just something to note in our adverse effects. In our out-of-hospital cardiac arrest, treatment with calcium compared to saline did not significantly improve sustained return of spontaneous circulation. There was that difference in dosing between the Denmark and what we do here in the United States, of that 735 milligrams versus just 1,000 milligrams of calcium chloride. I don't think that would necessarily have made too much of a difference in sustaining ROSC at all, but it is something to note that they do something a little different than what we do here. So generalizability might be a little difficult. They did only study one treatment strategy. So it was the epinephrine directly, or the calcium directly after the epinephrine. So there's thought maybe that if they used a different dosing strategy and maybe didn't give them right away, if they ended up giving epinephrine a little earlier, if there would have been a difference. And then this trial was stopped before the sample size was reached due to harm. So that is something important to note, that they didn't get all the patients that they needed, but it was stopped early due to negative effects from the calcium. So strengths and limitations. Strengths, it was a double-blind randomized controlled trial. So both groups were not aware of which patients were getting which medications. The bystander CPR rates were very high, which is interesting for an out-of-hospital cardiac arrest study. Like I mentioned earlier, there was the diversity in the arrest characteristics. So between the different rhythms, bystander CPR or not. And then they also noted in the supplemental that they looked at high quality chest compressions, and between both groups, they were similar. They were able to look about 60% of patients had data for both of the groups about their chest compressions, and both of them were similar. So there was no difference in how well the chest compressions were to make a difference between the two groups and their results. Limitations, as I mentioned, it didn't meet sample size and the study had to end early due to harm. There was a lower rate of shockable rhythms, so it's hard to generalize this study to the shockable rhythms when mostly it was our asystole and PEA patients. And there was confounding factors potentially. This other ACLS medications were given and those were not part of the protocol. So it's variable of which patients were getting which medications outside of the protocol itself. Just for final thoughts and conclusions, they did a year later long-term outcomes update for this study. So for survival at 1 year, there was 9 patients in the calcium group who survived and 18 in the placebo group. So still the calcium group at 1 year had less patients survive than the placebo group. And then survival at 1 year with neurological function, calcium group had 7 patients while placebo had 17 patients. So calcium still did not have the long-term benefit that I think that the study authors were hoping for when they decided to do this study. So the results of both the short and long-term outcomes do not support the use of calcium in every single patient with an out-of-hospital cardiac arrest currently. There are still some patient populations that would benefit, like I mentioned earlier, including hyperkalemia, hypocalcemia, and calcium channel blocker overdose. And these were not included in the study, so we can't really include those in our generalizability here because they were not included in the study. So we can't say if calcium is beneficial or harmful in those patients who are having cardiac arrest, but I still think that they are a patient population where we shouldn't hesitate to fully give calcium, like maybe we should be with giving calcium in every single out-of-hospital cardiac arrest comes in, which was what this study was trying to see. I just wanted to thank Liz Van Wert who helped me put this together. And then if anyone has any questions, I am open to questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.